The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines Podcast series. My name is Shannon McKernin, and today I'm interviewing Dr. Manish Shah from New York Presbyterian Weill Cornell Medical Center, senior author on treatment of patients with early-stage colorectal cancer, ASCO Resource-Stratified Guideline. Thank you for being here today, Dr. Shah.
Thank you. It's a pleasure and honor to be here.
So first, can you give us a general overview of what this guideline covers?
Yes, absolutely. So the treatment of patients with early-stage colorectal cancer is a resource-stratified guideline, and it focuses on the management of patients with early-stage colon cancer. It's different than the surveillance and screening guideline that was written simultaneously for ASCO as another resource-stratified guideline. We felt that this was a big enough topic that we should keep it separate. So it really talks about the management of pre-malignant lesions, as well as early-stage colon cancers, as well as rectal cancers. And the other aspect of this is that we really focused on how the guideline may apply in settings where they don't have maximal resources, so basic or limited settings as well. So I would like to talk a little bit about how the guideline was created, because I think that's an important aspect and it distinguishes it from typical other ASCO guidelines. So, the management of colon cancer or colorectal cancer, there's a lot of literature on this, and there are several guidelines that have been produced by colorectal cancer societies or surgical societies or from other countries like the EORTC or Japan or Korea or even the UK. So in fact, there were, I think, 30 to 40 different guidelines that we reviewed, and we felt that instead of doing a new literature search to kind of rehash much of the same information, we reviewed all the guidelines for certain quality measures to then select a handful of guidelines that we would use as the reference for each of our key questions or key points. And this was done in a formal process, the first by ASCO and Sarah, who was the ASCO staff who wrote the guideline, along with the members of the guideline panel. And in this process, I think that we have a pretty comprehensive guideline that covers the questions with the best evidence available.
So what are the key recommendations of this guideline?
Yeah, so we addressed several questions with regard to key recommendations. The first question, for example, was what's the optimal treatment for patients with colon cancer that would be clinical stage 1 through 3C? And we distinguish that from a non-obstructing cancer to obstructing cancers as well, because the management would be very different. And what we really sort of focused on is that these patients should have resection following oncologic principles. And ideally, they should have an en bloc resection by a surgical oncologist to give the patients the best chance of care. But I think what's unique to resource-stratified guidelines, what we attempted to do is sort of highlight the care that would be achieved in settings that have less resources. So a non-obstructing colon cancer in a basic setting should still have surgery and should still undergo an en bloc resection following standard oncologic principles. So that was, for example, one of the key points that was uniform across all the settings. Other things were how to manage obstructing colon cancers. So in more enhanced and maximal settings, sometimes there might be an opportunity to place a colonic stent, for example, by either a colorectal surgeon or by someone who has specialized training in the placement of these stents, then that would be a preferred approach in both the enhanced and maximal guidelines, whereas in a more basic setting, the recommendation was to perform a resection and possibly if required, if a resection was not possible, a diversion to overcome the obstruction in that localized setting. There were other recommendations that were also important. So, for example, in early stage rectal cancer, so clinical stage 1, T1N0 rectal cancer in a maximal setting, these are sort of low-risk cancers without adverse features like high grade or involvement of lymphovascular structures. The surgical oncologist and or colorectal surgeon might consider a local excision such as the TEM procedure, which is a transendomucosal resection. And in basic or limited settings, we would still recommend surgery in that setting following TME principles to achieve clear margins and a good surgical outcome, because we felt that in basic limited settings, the skill and the equipment necessary to do a local excision may not be available. Another recommendation that might highlight the differences between basic and limited settings versus more maximal setting is the optimal strategy for post-treatment surveillance. So this is after resection of a stage 1 to 3 colorectal cancer. What would be the best way to monitor and surveil patients? And this is with the recognition that the purpose of surveillance is to identify recurrence early at a time point where the patient may still be amenable to having local regional resection or resection of a metastatic lesion to change their outcome. So the current ASCO guidelines are to perform a medical history and physical examination in a CEA every 6 months for 3 to 5 years, have an abdominal and chest CT scan in high-risk patients every 6 to 12 months for 3 years, and a colonoscopy 1 year after surgery, and then every 5 years or so after that, as indicated up to the age of 75. And that's what we recommended in the maximal and enhanced settings. But in a more basic setting, the recommendation was similarly a medical history and physical exam every 6 months for 3 years, a CEA every 6 months for 3 years, a chest x-ray and abdominal ultrasound twice in the first 3 years, and a colonoscopy once in the first 2 years. And if a colonoscopy is not available, we recommended a double contrast barium enema, or for left side tumors, a sigmoidoscopy to try to surveil the local regional extent of the disease. So I think what we're trying to highlight is that we think that we can help patients for the management of localized early stage colon cancer, both for treatment as well as for surveillance, and that these recommendations may vary a little bit in more limited settings, but with these recommendations we can provide the best care for patients overall.
And so why is this guideline so important, and how will it change practice?
I think that the guideline is really important because we recognize that we're practicing medicine in the United States or in Europe or wherever we practice, but the levels of resources that are available to us, are not uniform. And so we really are getting to the aspect that cancer care is a global proposition, and ASCO should reflect that. And so the intention of these resource-stratified guidelines is to try to provide guidance into the best management for the indication across the spectrum of resources that are available. Interestingly, we've also heard from many people who practice in more resource-limited settings that they can use these guidelines to sort of, advocate for their own area, to say that, based on our availability, we fit in a criteria that's basically for limited, but we really want to be in an enhanced setting and lobby their governments or their local officials to sort of say these are areas that we can improve on to take us to the next level, literally.
And finally, how will these guideline recommendations affect patients?
Yeah, at the end of the day, I think it's very important that we remind ourselves that we're doing this to improve patient care overall. I think in maximal and enhanced settings, the guidelines kind of reiterate the best practices across panoply of guidelines that were reviewed. So I think that's a very important thing. It may unify the treatment plan across different practices. But I think most importantly, in basic and limited settings, it provides a benchmark for what should be done. I think, for me, one key thing was that even in basic and limited settings, we don't want to compromise oncologic principles for surgical resection. It's not appropriate to just resect the tumor, but leave some tumor behind to relieve an obstruction. We still need to manage that appropriately, and that is the expectation in a basic setting, for example. So I think that overall, wherever you are, this guideline provides recommendations to help manage the patient across the resources that are available to you. I think that's very important because we live in a heterogeneous environment where resources are not uniform across the world.
Great. Thank you for your discussion of this important guideline, and thank you for your time today, Dr. Shah.
Oh, it's my pleasure. Thanks for having me.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.